Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Jahangir John Asghar from Paley's Orthopaedic and Spine Institute, Florida, United States. Dr. Asghar is associated to the Paley's Orthopaedics and Spine Institute. He completed his medical education at the St. George University School of Medicine in West Indies, Grenada, and the orthopedic residency at the University of Medicine and Dentistry in New Jersey in New York. He finished a fellowship in complex spine and spine deformity at the Shirners Hospital for Children in Philadelphia, Pennsylvania. Before his time at the Paley's Orthopaedic and Spine Institute, Dr. Asghar was part of the team at the Nicholas Children's Hospital in Miami, Florida. He's board eligible with the American Board of Orthopedic Surgery. Dr. Asghar has been publishing for more than 40 times, and his charitable work in pediatric spinal deformities and scoliosis has taken him to service trips across the world. He has performed surgeries and aided communities in Asia, South America, and the Middle East. He's a founding member for the Society for Minimally Invasive Spine Surgery. If you've noticed, Dr. Asghar has delivered a couple of lectures on our channel, and which has already reached a huge audience. And today it's my great honor to bring back Dr. Jahangir John Asghar for this wonderful live program. Over to you, John.
Thank you, Hitesh, and I'm glad to be here. And happy Scoliosis Awareness Month to everybody. I think it's an important time to make sure that we're doing good outreach and managing our patients and teaching our patients about scoliosis. So one of the things we really want to talk about today is focusing on enabling technologies in AIS. So what does that mean? It's technologies in scoliosis that make the operation safer, easier, more effective, and more universally applicable. Right now, historically, the capacity to do complex spine surgery was limited by a number of factors. Now, as we have these newer enabling technologies, we can take on more and more complex cases, and we can also make sure that those can happen safely and effectively. And it also, in an indirect way, brings it more available to a larger group of spine surgeons as well. So the first thing we want to talk about is, the history of scoliosis. Scoliosis has been around for a very, very long time, and innovative treatments in terms of scoliosis have also been around for a very long time, whether traction or different forms of manipulation. These have been kind of progressing very quickly, but in the last couple of years, we've really started to take off. So I'm not sure the picture here on the left is the best way to go about treating scoliosis, or hanging somebody upside down is the best way to go about treating scoliosis, but this was available at the time. So, today's gold standard will be tomorrow's old standard. So we just got to kind of keep pushing the envelope in terms of developing technologies appropriately, right? So the goal here isn't to always be innovative. It's, to be innovative in a way where we're accomplishing and creating new standards of care and optimizing outcomes. So innovation for the sake of innovation is one thing, but innovation to achieve an improved outcome, that's a completely separate thing, and that's a harder task to achieve. Right? And also be flexible to change. Sometimes things that are old are new again, and sometimes things that are old new kind of can fall out of favor really quickly, and we can talk about some of those as well. So, anytime we adopt any new technology, it really is important to understand what the adoption curve is and where we follow on that. And so, it's a matter of time and experience. The more times we do something, the better we get at it, right? As humans, as animals, aren't very smart. And, a saying of my old partner is Dr. Schuffelbarger is repetition is the hallmark of adult education. So repeating something over and over again, it's the best way to kind of go about learning it. But every time you learn it, you make some progress, and then you take a step back and you make some progress. And it's really important to have a really critical understanding and being really critical of yourself and the technologies you use to make sure that you're doing a good job. So ultimately, where a lot of the energy in scoliosis has come is you can break things into preoperative part, intraoperative, and postoperative setting. And so actually a lot of it's always been on the intraoperative side, but there's been a lot on the preoperative side from software to AI. And really we want to make sure we understand what the problems are, how large the problem is, and then come up with solutions to solve the problem, right? So the first one is the EOS machine. The EOS machine is a great technology, and it's more and more available. But the benefit of it is several-fold. Number one, it's a low-dose slot scanner X-ray, and the advantage of that is it's the technology eliminates a lot of parallax, and it's digital, and we can really lower the radiation exposure to our patients pretty significantly. It can be 7 to 10%, or on the microdose, it can be 1 in 50. 1 in 50 times that of a normal X-ray. And that becomes very important in our populations as they get older, in our young population, because as they get older, remember, radiation exposure is a cumulative effect, and if we're exposing them already to multiple X-rays multiple times a year, this is a technology which has been quite helpful. The other aspect of that is really it allows us to improve our preoperative planning, and I also use it a lot for teaching. So when a patient comes in, an X-ray is one thing, but a model is a completely different thing. And when we are able to spin the model around, show the patient the model, and then show them what our plan is and what our goals are on the model and how that applies to the patient, that becomes very, very a powerful teaching tool. So not only is it an effective tool in terms of optimizing surgical planning, but it becomes a very powerful teaching tool for the patient, because the patient can engage, see, and understand what the goals of the surgery are and what the potential pitfalls are in a very tangible way, as opposed to something that's more indirect. Other aspects that we utilize is we take this information now that we calculate from this, and now we can use it, and because we've been collecting this data for years and years and years, we have this large patient data subsets. We can take this patient data and turn around and optimize the correction and deformity correction in a way where they're getting the best possible results. And how is that? Remember, scoliosis is lordogenic. That means that the apex of the thoracic curve tends to be very lordotic. And one of the things that has long-term ramifications, and really our goal is to make sure we restore the kyphosis. Historically, 20, 30, 40 years ago, that wasn't as much of an issue, or an conceptual understanding was more around derotation and coronal correction. But really, probably one of the more important things we can do for the longevity of an operation is do a good job of restoring that kyphosis as well. And so utilizing pre-bent or patient-specific rod technology, which is based off the preoperative planning, has been really, really important. This is a fantastic case of somebody who has had utilizing the unit rod system from Medicrea, which is now owned by Medtronic, of the changes that you see. So here we took a case, coronally about a 52, 53 degree deformity, not a big coronal deformity, but really what is the question? The question is the apical lordosis that you see there. That's a pretty significant amount of apical lordosis. And, what will the kyphosis correction do to that cervical spine, right? So in this patient, you see a good amount of mid-cervical kyphosis, and that is a compensatory response to the apical or the thoracic lordosis that the patient has across that apex. So theoretically, right, if we're able to restore the thoracic kyphosis, we should be able to correct that lordosis in the cervical spine, as well as the lumbar spine in a meaningful way. And hopefully that'll improve the longevity of the patient, not only at the adjacent segments, but now further down the spine because the alignment has improved. And you see that done very nicely here. And this is actually the 3-week postoperative x-ray versus the preoperative x-ray. So the preoperative planning does a really nice job of establishing the criteria for restoration. And then even though, you see that I probably could have, it was a stiff spine and I didn't get as much derotation as I wanted. That's why you can see the double rod sign. We had excellent apical correction, but the most important thing and the most impressive part of that is the predictive response of the cervical spine, which is outlined in the medical ear instrumentation. And I think I would tell you right now, this has me the most excited, right? Being able to predictably change uninstrumented segments and predict the changes, sagittal changes that you're gonna get in uninstrumented segments is quite a powerful tool. And again, I think of all the things that we have, it may be the one thing that improves long-term outcomes probably the most if once this technology becomes more universally available. The other part of it is GPS, right? Like knowing where you are at all times, right? Like, it's one of those things where right now, being aware of your surroundings, historically, when we would do Harrington rods, we would bring in a flat plate x-ray, we would confirm levels, we would put these hooks in. It was very much based on surgeon anatomy, which was an understanding of anatomy, which is up in the brain, and maybe the flat plate for localization. With the technology available nowadays, we've got to get better at that, right? And so what are available? So in terms of two-dimensional navigation stuff, we utilize the TrackX. TrackX is a 2D navigation, fluoroscopic navigation system. And the benefit of this is sometimes, we'll discuss the differences between the 2D and 3D, but a 3D navigation system is CT dependent and can oftentimes require a lot of exposure, and the setup time can be more, and the cost can be a little bit prohibitive, where something that is a 2D navigation system that attaches onto your fluoroscopic unit, that has a number of efficiency advantages as well as cost advantages associated with it. And that's where it's been quite nice to be able to utilize in that thing. So here's me registering the instruments and the lengths of the instruments while I for a small Tlift for a spondylolysis case that I had. The other aspect of it is in 3D navigation, right? That's the O-arm spin. And that's something that we're well aware of. That's where we're utilizing implant technology. Right now, it's more than just screws. We can actually plan out osteotomies. We can plan out with navigation. We can really do a good job of planning out interbody cage position in revision surgeries, where and how we go about attacking removing instrumentation as well, not only from the pedicle screw standpoint, but also from the disc standpoint as well. And then, here's the aspect around the navigation portion of it. And I'm using a little bit of augmented reality as well, but this is 3D navigation. This is CT dependent. Now, this has been around for both these technologies have been around for a very, very long time, but the software and the capacity and the technology has evolved to the point where it's much more universally applicable. And so it is no longer about putting a screw in, but we can usually use it for very complex techniques. And so for me, for a lot of what I end up doing now is I do a lot of prone lateral surgery where I do a lot of revisions or XLIF cases or OLIF cases through a prone position. And the navigation makes that very easy, efficient, and quick and safe. and that's the most important thing. So single position surgery for me is truly now single position, where I can do my posterior work, a good posterior decompression, and oftentimes come and do the inner body work. And this is all can be navigated, where my exposure to fluoroscopy is very limited. The patient's, my OR's team's exposure to fluoroscopy and the X-ray radiation is very limited. And that's been really good. And it really lets you optimize implant position as well. And again, these are other technologies. This is utilizing, we're utilizing the Pulse platform, which is the NuVasive one. And I use both. The Pulse hasn't been quite released yet, but it allows you to under power, place screws. And here I'm placing perc screws in on a cadaver. This is also where ideally some of this stuff in the intraoperative setting will be start to be integrated, where the neuromonitoring, the navigation system, and other enabling technologies, whether it be ultrasound or other anatomic technologies, will start to be integrated into one seamless unit, as opposed to multiple units, which are kind of what exists now, where we're working on multiple units and multiple setups in the OR, where the potential for an integrated unit, where the things start to become seamless, where the navigation platform, the neuromonitoring platform coordinate, because navigation neuromonitoring is a form in some way of navigation, especially depending on where you are and how you go about doing it. Here we are doing the O-arm spin. Our OR setups really require a good amount of, we have a pretty, and the registration portion of it, we have a pretty efficient setup. So for me, a multi-level Tlift or a single level Tlift is about an hour and 20-minute case with the navigation. Anterior, posterior XLIF and posterior decompression, again, it's about an hour and 30, an hour and 45-minute case as well. So the navigation, once you understand the workflow, kind of really makes it efficient and easy to do in a very quick and timely way. The other aspect of all this becomes the robotics aspect of it. And so the video, I'm sorry, here isn't really working, but the advantage of the robot and the robotic aspect of it will often be as a next step. So here's my partner, Dr. Schuffelberger, who assists me on my cases. And a lot of what we end up doing here is utilizing the navigation to help us, but I still need a set of hands for holding the retractor in place. I need a set of hands, extra set of hands to allow me to do some. So as we move away from the robot being a trajectory device, which is what it is now, I think the next generation of steps, and you are already starting to see it, is going to be a first assist device. So holding the retractor in places, maintaining the alignment, understanding changes, and being able to manipulate it for position is really what it's going to be. And this is the Mazer robot. You see the stereotactic pin that goes into the PSIS to ensure that the spine is it's referencing off of the same points. I think the other thing that's really innovative and exciting and is developing very, very quickly, but there are pitfalls associated with it that are the non-fusion or the magic or the non-fusion technologies. Non-fusion technologies specifically right now are the tether and things like the ApiFix. And I'll make a comment on the ApiFix, because there's recently an article from the JBJS on it, but we'll start with the tether, right? These are both of them are immature technologies which have a lot of potential, but aren't evolved to the point where they need to be used on that they're the standard of care. With understanding that, the potential benefits of, say, a tether is motion preservation. Right here, we have it more in the thoracic spine, but ultimately, the motion preservation in the lumbar spine is as or equally important. I tend to be a little more conservative in the lumbar spine, but that's really where the bread will be buttered over time of whether this is an effective treatment option. So now some of the pitfalls of the tether are always going to be the reoperation rates right now are higher, regardless of how you slice it or dice it. They are higher than a AIS or a selective thoracic fusion, which would have been a perfect indication for this case as well. The other part of it becomes, the other failure part of it is the rod breakage portion of it. And aesthetically right now, the results aren't as good, right? The aesthetic results in a teenager with a large thoracic hump or waist asymmetry, as you can obviously see in my lumbar curve, residual lumbar curve, aren't as good as that of a traditional selective thoracic or a traditional fusion operation. And those are things we have to be honest and clear about. Other technologies that exist nowadays are the ApiFix. Some of the concerns around the ApiFix are, according to the JBJS article, and these are things that are the rod breakage and failure rate, which is quite high with the ApiFix, at least according to that data. I know that the Orthopaedics had put out a rebuttal of it. I'm a little hesitant and I'm a little concerned about the technology around the ApiFix, especially in the lumbar spine, because I do think it has an ability to create flat back deformity. So I am very conservative with utilizing ApiFix. And the indications I would probably use it for was like a 1A right curve, which is a long, or a King 4 curve. Those are long curves where distraction is a good thing, as opposed to things where there's multiple curves, or in the lumbar spine where it would create a flat back. And I counseled my patients very heavily on the rod fracture issues associated with it as well. But again, with these things, it's a nice technology that's evolved and grown a bit as well. Magnetic rods are another thing that are quite nice, but they also have their pitfalls. And like in the last couple of weeks, we've taken 2 or 3 patients on to final fusion from their magnetic rod, and the amount of wear debris that the magnetic rod still creates is actually quite substantial. And so, although the magnetic rod in concept and idea is great, in action, it hasn't quite lived up to the expectations here. I think some of the issues around it are the mechanism, the strength of the mechanism, and just the nature of growth over time, right? Like it's just not able to achieve the forces over time, and they either bind up or things. But at the same time, this is a patient of mine who visits us from Panama. They are absolutely ecstatic because he visits me once every couple of months, and I do a lengthening, and then he goes home. No repeat operations, no concerns. He goes out and plays, and for him, he's done very, very well despite some of the pitfalls of a magnetic rod. And in many ways, I do think it's very vastly superior over a traditional growing rod, but it is very important to understand that it has some limitations in substantial ways. For me, the kind of the most exciting aspect of this has been the teaching aspect of technology. Right now, a lot of what I end up doing is, and this has been sped up by the effects of COVID, right? I do a lot of teaching in the OR. I've always had a lot of visitors in the OR, fellows, and some of that has been limited by COVID. That things are starting to open up in our world now, and I know India's had it very tough, but in Florida, Things have opened up, and we still have a basal rate that's pretty high, but but what we can do now is remotely through a number of very cool things have remote surgeons experience surgery. The advantage of it, specifically utilizing the IMRTech technology, is it allows for patient setup and understanding of the way the room is set up. So not only, remember, the surgery has multiple parts to it, and one of the important parts to surgery is really the not only is it the technical part of what the surgeon does, but how is the room set up, is the workflow around it. And a lot of times when you're observing videos, you lose that live experience of understanding the workflow and what the team is doing. And here, this is really optimal for that. So you can see, and when you put on the headset, go back to that. When you put on the headset, which is very similar to the one you see here, it allows you to circumferentially see the room. So you can look over to your left and you can see my scrub nurse setting the table up and seeing exactly how she's set it up. You can see myself working, and then there's some windows on the bottom which you can expand open, and you can see my preoperative images, my intraoperative images, and you can, and then you can also have a live discussion with me about questions around my indications. A lot of times I'll have PowerPoints up as well to make sure that the surgeons have a good understanding of what they're seeing and why they're seeing it. It's been a very nice tool to really be able to engage the surgeons and teach them well about what the thing. And what I do is, I find it as a very well see one, do one, teach one kind of things where people will utilize this. They'll oftentimes go to the lab, and by the time they've done both, they're very comfortable with understanding the technology and taking on new procedures, and especially with like things like the prone XLIF or prone lateral. It's been really important for me to kind of get them to go on and be able to engage me in a live setting that way. So, I love technology. I use it a lot. It's been an integral and a very important part of what I do. And it is very important to be used, and it's very important to push the envelope, but it's also very important to be critical of oneself, right? And understanding what you're learning, the potential benefits of it are in your hands. It's also very important to understand what the pitfalls are and optimizing your workflow. So a lot of times with the technology that's coming in, I'm having multiple discussions on how to make it more efficient and make it work better in my hands, right? And the analogy I always give to somebody is, um, uh, in terms of surgeon skill levels, right? 5% of the world are horrible surgeons. 5% of this world are naturally gifted surgeons. That's just based on the bell curve. 90% of us fall naturally in the middle. And how do you move up that scale, that bell curve to a higher level? And that's really by being very methodical, critical of yourself, and utilizing technology when you can in a way that makes you more efficient and improves your safety and outcome. Understanding the learning curve is really important in that, right? Understanding that it's going to have pitfalls. So you're going to have days where things are going to work seamlessly and it's going to be awesome. There's other days where it's going to be very difficult. Also, don't be dogmatic, right? Dogma is a blessing, but it's a pretty strong curse, right? So if we follow a tenet which is not grounded in fact or data, it is important for us to be able to flip around and say, look, we need to change, right? And as the data comes and as our understandings evolve, that dogma it's okay to move away from it. And I think sometimes, we lean too much on dogmatic thought, and that puts us in a lot of trouble and prevents us from progressing forward. And I think at that point in time, I'll end my talk, and I'll open it up for any questions or concerns.
Thank you, Dr. Asghar, for yet another brilliant presentation from your side. Can you stop sharing if you don't mind?
Yes.
Yeah, so a couple of questions, Dr. Asghar. One is, when I looked at some of the new technology that has emerged, there's a lot of talk on sublaminar polyester bands instead of the conventional in the Lukey system. So what is your take on these new sublaminar polyester bands?
So the sublaminar polyester bands are quite nice. So we'll go over the pros and cons of them. So the sublaminar bands, because of the surface area associated with them, disperse force much better than a traditional Lukey wire will. And so there's a huge benefit to the force dispersal. And they're quite powerful in terms of as a corrective mechanism. I do use them frequently as a bailout or in ways to augment something that I'm already doing. So in my practice, I'm still very reliant on the pedicle screw technology, which has been there for a while, but I also will often use the sublaminar band in cases like neurofibromatosis is a phenomenal case to utilize them on, because of the fact that in NF, the pedicles are so dysmorphic or dysplastic, you may not have any other fixation point. Oftentimes also as revision cases, it's great to use on. And also in cases where you're just not comfortable putting screws across the apical region. And some of the data around sublaminar bands across the apex has been quite phenomenal. My thing is why I don't use them more often is I tend to be averse to trying to have anything in the canal. And the example I always give everybody is around hooks and wires. There is an incidence of stenosis that can be related to that, or wire migration that can be related with that. And so with the sublaminar band, the fact that it's braided and the way the scarring and stuff may happen around it, I do have some concerns over the long term, but ideally, I think it's a great technology, and it's really, really good, especially if you don't have a safer way to correct across the apex of a large idiopathic curve.
Thank you, Dr. Asghar, for that. And what is your experience with the use of 3D printing for your pre-op or even intra-op?
I use 3D printing quite a bit, and I think I probably but I use it less now. So 3D printing a spine is fantastic for planning and just having an intraoperative roadmap. And so for some very complicated deformity, I still utilize it. As navigation and robotics have improved, some of those things are planned a little differently. And so for me, I've moved, again, there are instances, especially with 3-column osteotomies or corpectomies or very large deformities, where I still think it makes sense. But in most of my cases, I've started leaning more and more on the planning that I get from the navigation side. So, but I do think there's a huge value to it. And especially if you don't have access to some of the other technology, as the cost associated with it, the barrier to entry for 3D printing goes down, it's a great way to take that on. I think the future of 3D printing is gonna kind of continue to follow into that patient-specific technology, and as that improves, then I think we're gonna be in a better spot. But that's really where I think it is.
Thank you for that. And also, you mentioned about the EpiFix device, right? And yes, is it FDA approved, the device?
So the device is FDA approved, and is being utilized in the United States. I have been pretty hesitant to utilize it, and I have some significant concerns around it. However, my partner's used it and he's had good results with it. However, there is Maurice de Kluver just had a paper in the JBJS, which showed a pretty high failure rate associated with it, and so they were able to get an approval through some kind of collection of data, but I do still have significant concerns about its long-term viability, I think, because of the complication rate associated with it and the rod fracture rate associated with it.
Thank you, Dr. Asghar. Just one last question before we wind up the session. And what has been your experience with vertebral body tethering? Because there are a lot of surgeons in the US who have picked up vertebral body tethering. And do you think it's only useful for those very early or very mild cases? And do you use it at all?
I do. My indication for vertebral body tethering is basically between a 45 and 60 degree curve with growth remaining. I don't think it should be used for right now. I don't think that the data and the technology is mature enough for it to be used in skeletally mature patients. I also, when it's utilized, I use it primarily for. I do counsel the patients heavily on the tether breakage and the reoperation rate from it. I tend to be very transparent with the patients regarding the issues associated with the tether, and then we go from there. But what I find is you have a dichotomy of patients. You have patients specifically asking for it, and then other patients who are asking for traditional fusion. So when they ask for it and they're the appropriate candidate, I'm okay with it. But I don't think, I think the term that has been thrown around, ASC for adult patients, which is an anterior spinal correction, utilizing the tether, it makes fundamental sense to me. And so, and it's, I'm happy to discuss that, but I think it's one of those things where there's some dangers around that. And I think even if you talk to the surgeons that do it, they're talking about coming back 1-2 times, multiple times to make sure that the correction happens. So, and cutting things like the disc, which I think I have some concerns when you cut the disc or you do any sort of annulotomy, effectively you're creating a situation for accelerated degeneration and fusion. So, and if you're trying to fight that, and then you're doing something traumatic to the disc, I think I think you end up at a loss at that point.
Maybe we need really long-term outcomes before we come to a conclusion, isn't it?
Yeah. I mean, I think it's one of those things where on the ASC side, I think there needs to be a lot more data, even in the short term, because there isn't any short-term data. It's just people doing it. On the tethering side, there's starting to be good 5-year data. The goal is 10, 15, 20 years, what happens with these patients. But we do know in that 2 to 5 year data, reoperation rates are higher, aesthetic results aren't as good. But again, mobility is something that's a positive thing. So we have to figure out when and why to use it. So the short to medium term data is good, with some pitfalls associated with it, but the long-term data is completely lacking.
Thank you, Dr. Asghar. I think that's all the questions that we have for this session. Yet another fantastic lecture from your side, and I'm sure this lecture is going to benefit a lot of people all over the world.